The Next Breast Thing podcast is primarily funded by the American Society of Breast Surgeons. The support of sponsorships helps us offset some production costs. ASBRS does not endorse or co-promote any company, product, or service mentioned.
This episode of The Next Breast Thing is made possible in part through the generous support of Myriad Oncology and from Solventum Prevena Therapy.
Myriad Oncology provides a portfolio of advanced genetic and tumor genomic testing solutions, including risk assessment, screening, tools to aid treatment guidance, and survivorship planning. The Myriad Oncology offering is designed to meet the unique needs of oncology specialists and their patients across each step in the patient care continuum.
To learn more, visit myriad.com/oncology.
Solventum Prevena Therapy has demonstrated a significant reduction in surgical site complications, infections, and readmissions. Take a proactive risk management approach. With Prevena Therapy, learn more at Prevena.com. That's Prevena.com.
Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast, wherever you listen to podcasts.
On this episode of The Next Breast Thing,
The impact and opportunity of artificial intelligence for breast surgeons.
If we can use data to solve these problems in a better way, then we're going to make lives better for everybody.
So when we think about AI in healthcare today, what are we talking about?
AI can analyze this and say, you know what? We can help surgeons get better outcomes.
So how today does AI make your job as a breast imager better? How does it?
This is a study that came out, I think, last year in the Annals of Internal Medicine that looked at the cost, not in financial terms, but in outcomes of false positives.
So what's our goal? What's the end game?
What can good AI do? AI can right now.
This is Carla, Ellie,
Michael,
Susie,
And Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country,
Inviting you to journey with us into the science of breast.
through the heart and soul of our breast community.
from advances in procedures and patient care to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.
Welcome to the first of a two-part episode on the impact and opportunity of artificial intelligence for breast surgeons, and not just in the care of our patients, but hopefully we'll get more into how are we using this in our everyday lives. But let's face it, AI has already slipped in to our day-to-day in life. As breast surgeons, as breast imagers, people are using it to draft notes and predict risk for our patients.
Then, of course, there is the patient side and their push to use AI at every turn, sometimes in ways that might make us feel a bit uncomfortable. Here in part one, we'll examine the present state of AI for breast surgeons. We'll attempt to separate hype from reality to examine where AI is actually changing practice today, what it means for quality and safety, and how to stay clinically in charge when AI is in the room.
Fortunately for us, we don't have to navigate this topic alone. Joining us today is Dr. David Gruen. David is the former IBM Watson Health Chief Medical Officer, specializing in women's imaging and body imaging. He lectures frequently on healthcare technology, including artificial intelligence in healthcare. David has also lectured and published extensively on breast care and AI, and was the first radiologist in the country to become a program inspector for the National Accreditation Program for Breast Centers, or NAPBC. David, welcome to the Next Breast Thing podcast, and thank you for being with us in this two-part series.
Thank you very much for having me. It's an honor to be with you all to talk a little bit about something that all of us are dealing with every day, which is how we integrate AI into our personal lives, into our professional lives in a way that we're comfortable with, our patients are comfortable with, and our colleagues are comfortable with. We're at the beginning of a really exciting journey.
So it's so interesting how life comes full circle in so many ways. What my co-hosts probably don't even know is David and I were residents together at Cornell, and I was a surgery resident, he was the radiology resident, and I was always so grateful when David was the one on call. You know, when you go into the radiology reading room in the middle of the night and you get some grumpy resident or attending that you're asking a question to, David was always so pleasant and just great. And I have to say, David, you haven't changed. I mean, you're still that pleasant, inspiring guy. So that's my story about you. But how did you get into AI? You've always been a clinical radiologist with a focus in breast, but how'd you escape into the world of IBM?
One of the things about medicine, it's really a trade. Most days we do the same thing. We repeat what we do, and we're pretty good at it. The number of things that we have to do that are outside 2 standard deviations are really, thank goodness, uncommon. We're basically very skilled tradespeople. We have a specific set of things that we do, and we try not to veer too far from it. After taking care of breast care patients for a long time, it came to me that we're not doing as much as we can at a population level. Yes, on a one-off basis, I can read a mammogram and find a breast cancer. I know that I'm going to miss interval cancers because we all do. I know that I'm going to probably have too many recalls that I don't want to have to call back. I've always strived to do better myself, but also believe that we as an industry could do much better, and that couldn't be done by any one individual in any one reading room in any one hospital or medical center. We needed to use big data to transform what we do, to answer the questions that really need answering. So when the opportunity came to join IBM, and at that point Watson Health was looking for solutions using supercomputing and big data to address breast cancer and prostate cancer and liver cancer and lung cancer, and to solve problems with data, I jumped at the opportunity to think this is a way to make an impact on population health much bigger than any one doctor can do. It was also a fundamental belief that we have tremendous disparities in healthcare, that if you happen to have insurance or education or family members or be in a community with lots of healthcare, you get pretty good healthcare. But I have a friend who grew up in Maine, and she said that she and her mom used to have to drive 100 miles to get a mammogram. And then it was the only choice. I have another family friend who 2 weeks ago had an aortic dissection and within 15 minutes was airlifted to a major medical center and survived, but only because he had incredible healthcare and incredible community and smart, talented people who knew what to do. And yet in breast care, we still see women who show up with late-stage breast disease because they don't have access. We see general radiologists taking care of patients with recall rates that are too high and sensitivity that's too low and are not doing what really good breast radiologists can do. And this is all data. And if we can use data to solve these problems in a better way, then we're going to make lives better for everybody. And so that's what drew me to this incredible world of leveraging technology to help patients have better outcomes and doctors have better outcomes.
This world is incredible. We're all physicians, and thankfully we love what we do. And as you said, we make a difference, not just on the individual level, but that individual, that patient sitting in front of us has family members and friends and everyone who loves them. So we affect all of their lives. But when you're talking about population, that really is a game changer because it helps us be better at our jobs. And that really does change the tide.
Well, that's right. And we're using population data to make individuals better. And since I've been doing this AI kind of stuff, it's really changed the way I think about each patient. And I'll give you a great example. Carla, a few moments ago, we were talking about the value of MRI versus not getting MRI. And I don't want to put words in any of your mouths, but one of the biggest criticisms of breast MRI is that we find things. and we don't necessarily change outcomes, but someone with newly diagnosed breast cancer, we're going to find 16 little foci of nonspecific enhancement in the opposite breast and 4 in the same breast. And this poor woman is going to have 19 biopsies and finally say, screw it, just take them both off, rather than dealing the way we should do, which is doing a partial mastectomy and treating her with outcomes that are going to work. When you start to think about problems like that, AI is the solution, because AI can analyze this and say, you know what? You don't need to look at anything in the contralateral breast. That's all physiologic. Forget about it based on things that we can't begin to understand. But you didn't actually see this tiny little area of enhancement right behind the nipple. And so I know you were thinking about skin sparing, but this is highly suspicious going right to that terminal duct. So that's the kind of way we can use AI based on big data to impact patients at a one-off. Get them that right extra procedure the first time so they get the right operation. And I think we can help surgeons get better outcomes for their patients and explain to patients why they need it using AI to justify our decisions.
I hear there was a really great debate a couple years ago at the breast surgery meeting about MRIs.
At every meeting about MRIs.
I can't listen to a podcast these days and not hear about AI. I mean, you've probably been in the AI space for many years, and we're doing it before people were talking about it all the time. It's all I hear about anymore. I mean, this year is the year of AI. And so when we think about AI in healthcare today, what are we talking about?
That's a great question. So I think it pays, Carla, to think about what AI is generally. I think about AI as software. It's basically computer programming that can mimic what humans do. So it's associating technology with a human mind, learning, problem solving, a deep level of analysis that can depict, mimic human function, and take complex amounts of data, assimilate them to make educated decisions. Now, the power of that is that it doesn't tire, and it can take in data and perceive things that might be beyond our perception. That's kind of why imaging is so successful, imaging AI, because I'm only as good as my retina and my brain can process, but AI can see things and focus on things that I may overlook or simply can't see. But AI, this automation, can touch all aspects and is touching all aspects of our lives. We've been on conversations with someone and it's been recorded by AI to make sure we don't miss anything. How many of us complain when we go into Kennedy Airport and all of a sudden we're whisked right through international arrivals? Well, guess what? That's AI. It's recognizing that we're not particularly terrorist threats, that we are who we are, that we're not at risk to be importing anything bad based on all this deep data that maybe we should be afraid is known. But at the end of the day, AI is incredibly powerful at solving a lot of common problems in our lives.
David, we've all heard this quote that AI will not replace the physician, but the physician using AI will replace the physician that's not. But we don't really have any training on how to use AI. You've done this through IBM, big institutions like Mass General with Connie Lehman, and they'll start these programs. But how does something like this filter out into the rest of the world where we are trained to use AI in a functional manner?
AI is getting much more complicated. Right now, most of the AI solutions that are available solve one specific problem. And I think for people who are thinking about where AI might help them, they should start by asking themselves, what are the problems that I'm facing in my day-to-day practice that can get better? Susan mentioned before we started, clinicians are using AI in the exam room as a second set of ears so that we can actually focus on our patients and not have to transcribe notes. That's a great use for AI. You don't have to be an AI expert to have somebody automate your note-taking. But what if it could go a step further and say, you might not have picked up on this, but the patient's on 5 medications and one of them doesn't align with the other 4, and you might not know that. Or, for example, now I'm just spitballing because I'm a radiologist. Maybe you want to give Neurontin perioperatively, or maybe you want to give Keflex perioperatively, and you don't pick up that they're on some other medication that is going to interact with Keflex because they've got some LFT abnormality that's interfered with their P450s in their liver. All that information is not in our normal realm. You're going to give pre-op orders. What if AI could save our butts by assimilating this data and putting a little flag up and say, wait a minute, Dad had a bleeding diathesis. You may not have picked this up, but you may want to send this patient for a bleeding test before you send them bleeding time before. And so all of these ways that AI can extrapolate by culling information, you don't have to be skilled in it. You have to just recognize they can help you solve some problems.
Is that even available today? I know that ambient listening is, and it can write a note for you and kind of cut out some of the chit chat.
Those are the next steps in a lot of the ambient listening, is to pick up other. But again, coming back to our definition of AI, we don't begin to use 1/millionth of the amount of information that's available to make really good clinical decisions. In our 15 minutes in the exam room or my 5 minutes reviewing a mammogram, I don't have time to go into Epic. I don't have time to dive into history. I don't have time to dive into all their other studies that may help me. Family history, what does their biome look like? And, I'll give you an example. When I was at IBM, there was a research project that was looking at LFTs and thyroid function tests and correlating them with likelihood of different types of breast cancer. Who knows what's out there that's going to predict outcome? For all we know, that women with an elevated TSH are going to have a higher likelihood of positive margins. Now, I just completely made that up. That doesn't exist. Don't take that to the bank anywhere. But that's the kind of example of the assimilations that are just beyond our grasp to make our care better. Stay tuned. This is kind of futurism, but it's at our fingertips.
There is so much potential in this. Real, what we're doing today, and then the unrealized, like what does the future hold? So how today does AI make your job as a breast imager better? How does it make you better at your job?
Let's face it, screening mammography is an amazing test, but it's far from perfect. We know that we in this country with annual screening call back 10% of patients, and we know that the vast majority of them won't have breast cancer. We know that many women require biopsies. Most biopsies are negative. And I want to share some data with you just because I think it's so interesting. This is a study that came out, I think, last year in the Annals of Internal Medicine that looked at the cost, not in financial terms, but in outcomes of false positives. And so what this study showed, when I looked at more than 3.5 million women, was that false positives occur in, as we know, 10% of mammography, right? We call people back more than we need to. After 10 years of annual screening, 50 to 60% of women are likely to have had at least one false positive mammogram, meaning we call them back for something and it turns out not to be breast cancer. 7 to 12% of those women are going to go on to biopsies that turn out not to be breast cancer. Again, an awful lot of unnecessary imaging, biopsies, intervention, anxiety costs, pain. Those are the harms of mammography. Perhaps the worst part of it is that 16% of women following a false positive mammogram won't come back for routine screening, and 10% won't come back following a false positive biopsy recommendation. And so if we're doing this to women in their 40s, when their likelihood is significantly less than in their 50s and 60s as they age, we're not going to have those women back when we need them at the point where they're most likely to have breast cancer because we've intervened with false positives. So we need to be more accurate. We need to be more precise. We need to reduce those false positives. We need to be more sensitive and pick up the cancers at an earlier stage. So we decrease our number of interval cancers. We decrease our false negatives of mammography. And I really believe this is where AI right now can and is making a big difference. We know that with AI, functioning as a second reader, even functioning autonomously in some studies in Europe, it does as good a job or better than radiologists. Radiologists plus AI has been shown to outperform better sensitivity, better specificity, and shorter reading time than radiologists alone. And that's a home run, right? We're finding more cancers. We're calling back fewer people. We're doing it faster. There are not enough of us. So that's a real life application that's being used right now for AI and making a big difference for radiologists.
So what's our goal? What's the end game? I'm going back to the terms that you used of false positive and unnecessary biopsies because they're only unnecessary in retrospect. We didn't know that it would be benign. If we knew 100% of the time it would be benign, we wouldn't do it. So what's the goal? Because we don't want to miss any. In the art of not missing any, we're going to have false positives. Let's be honest, since we're all physicians, how much of this is defensive medicine?
You're 100% right. We're never going to get to 100%. But
should we? But should that be the goal?
We can do better. And
I agree.
for example, there are great differences between those who do a lot of breast imaging and those who don't in terms of what we predict needs a biopsy. So I, as someone who does this day in and day out every day, I'm comfortable ignoring calcifications because they're little rosettes and I know they're benign, or they layer and I don't have to bring them back in 6 months to prove that this is milk of calcium and benign. And someone who doesn't do this every day might not be as rigorous or as comfortable and is going to send that person for a stereotactic biopsy and say, thank goodness, Mrs. Smith, those calcifications are benign. And if you ask some really good or consistent breast radiologists, they would have said, yeah, didn't need a biopsy. And the same is true with other modalities. We biopsy fibroadenomas because we don't have good data to show that we can ignore. I know the ASBRS is working really closely to change the guideline. For example, in young women, a 16-year-old with a fibroadenoma does not need a BI-RADS 4. She did not
publish it.
Abnormality. And you did publish this, right?
It was just published with SBI.
That she does not have with a fibroadenoma, a BI-RADS 3 does not mean she has a 2% likelihood of breast cancer. So we need to do this differently. We need to give a realistic pretest probability and then act accordingly. And so where do I see us going? We're never going to get to zero. Look, a good AI doesn't find half of the interval cancers, but it can decrease those interval cancers by half. And that's huge. What can good AI do? AI can right now triage women to risk. If we can identify the 10% of women who are at the highest likelihood of developing breast cancer and intervene, whether it's with supplemental screening or more frequent screening or with risk reduction. Maybe those are the women who need to go talk to their medical oncologist about tamoxifen because they are at such high risk. Now, this is not straightforward. To say to a woman who has no family history and nothing else going on, you're at high risk. We don't know which breast, we don't know where, but the computer says, the black box says you're at high risk. This is difficult stuff. If it's accurate and we can say to a woman, you may not, but you're at certainly greater risk on average based on you than your neighbor is, and we don't want to ignore you, then we can have good outcomes. For years, we've done risk reduction mastectomies on women who are carriers of BRCA mutations, and a significant percentage of them will never get breast cancer.
That is true. The key is figuring out which ones will and which ones won't.
Exactly right. And so imagine if AI could look and say your likelihood of risk is you're in the top quartile or you're in the bottom quartile, it's safe for you to keep going for a while because based on our really good data, and it's not perfect, it's really good, you don't need a mastectomy yet. Have your kids do what you want to do and come back in 3 years and we'll test you again. But you're safe because your score is so low and there's so much good data to show that we don't need to make this decision today. Right now, they all need risk reduction surgery because we don't know which are the 50 or 70% who are going to have a bad outcome.
I think radiologists clearly have embraced AI early on for obvious reasons, for a lot of the reasons.
Some of us, not most of us.
Well, I was just going to say, I know lots who...
Well, maybe not. I think there are workforce concerns, but I do think the technology lends itself to it. We've talked a little bit about ambient listening and workflow issues. I think that's where I have seen it with partners of mine and people in surgery using it. I feel like I'm seeing AI being advertised a lot with different companies, their technology being advertised as AI to help us in the operating room. But I'm not sure that I can say in 2025 that me as a breast surgeon, other than potentially some workflow issues or note creation, which I'm actually not using that just yet. Susan and Michael, are you guys using AI?
I'm using it in my life. I write business plans with it. I write proposals with it. It makes that part of my administrative job infinitely easier.
We just got internet last year, so I'm a little low on the uptake, but I'm not using it, no.
Michael, you are.
Okay, I joke that I haven't had an original thought in 6 months when you introduced ChatGPT to me, so I just turn it on and let it talk to my wife. But I'm using it like you. Usually I'll write an email and say, make this nicer. But for diagnostics, things like that, I'm not. It helps in writing talks that you can get references pretty quickly without having to Google it. That has been beneficial. But in the day-to-day dealing with patients, I don't interface with it.
And most people don't. Carly, you're right. There has not been widespread adoption, even in the breast imaging community where the data is so compelling. And there are a handful of reasons. One, it's expensive. The margins in radiology are low. And for me to take $3 or whatever the number is out of my interpretation fee for every mammogram to send it off to a company to analyze when the data doesn't say that I have to and the courts don't say I have to and patients aren't demanding it, most practices aren't doing it. And in fact, some are and are actually charging patients. And we can talk about whether that's appropriate or not, but most doctors are not. In the surgical realm, there are solutions that are available, but they're not in widespread use. They're mostly in small pilots. So for example, there is an AI program in companies called TumorSite Viz that does 3D AI-driven surgical planning to help make better incisions and surgical approach and clear margins and make sure that you know exactly where you're going. And if you ask probably most breast surgeons whether they need to know help to know where to make the incision, you'd say, I'm not paying for that crap, right? Like, you're going to tell me after doing this for 20 years where to make my incision? I think there is really good data that shows that there is AI that analyzes margins of specimen radiographs far better than I do. The generic radiologist. We're pretty good at identifying the mag seed or the localizer and the clip. And if there's an irregular mass, or if we see calcifications truly streaming to the edge of the specimen, but how good am I at predicting likelihood of positive margins? Flip a coin. So that's available right now. And most people aren't using it, aren't adopting it. They're not buying or embracing the technology. It requires a multidisciplinary approach. It requires a partnership with your radiology and surgery to work together. There are a lot of steps to adopt it. And it gets back to what you asked Michael earlier, is what are the problems I think I need to solve today? We accept a certain amount of margins are going to be positive. But I think every day about solutions that would be better done by AI. Let me give you a great example. What do I do with a lymph node where the cortex on one image measures 3 millimeters? And if I zoom in, I can make it measure 2.8 or 3.1. And if the tech measures it at a slight angle, it becomes 3.3 because they're not perpendicular to the cortex. And she had a COVID shot last month, and so we know it's bigger. And she's got 15 millimeters of DCIS and nothing that would suggest she's got in a fatty breast, nothing that looks worrisome. And she's got a 2.9 millimeter lymph node. AI would say, I can analyze that node and the pretest likelihood of lymphedema is X and the pretest likelihood of malignancy is Y. So don't do a biopsy because your complications are worse than your yield.
And that's the predictive AI, right? I'm just simplifying this for myself, but they're kind of gathering all that data of lymph nodes that have looked like this and situations that have looked like this. And they're telling you essentially the likelihood of this coming back as positive is very low, so you shouldn't do it. That's what that is calculating quickly. These are things we've been doing, but it just takes us a million years and clunky data.
And we're not so great.
We're not doing it in the real time.
We're biased by our last experience. Well, oh my goodness, always woman with a 2 millimeter node was positive, so you need to have this node biopsy. Or her husband's wife is a lawyer, so you need to, we're biopsied by things that are irrelevant. And AI can help us eliminate all that noise. And the same is true for treatment. Maybe all women don't need the full course of radiotherapy, or for that matter, any radiotherapy, based on something in their tumor characteristics under the microscope or under the mammogram or under the MRI, that if we can get to the biology of this disease and know that don't radiate her, save her for another day, right? Or she needs something else, or she needs chemo, or, our nomograms that are data-driven based on a study or two. There's so much more data that we can use to make personalized decisions based on this person's individual biome, their phenotype, their genetics, their chemistry, their cardiac enzymes. Who the heck knows what the correlate is that we can pull out to make really individualized, personalized decisions?
You've sold me. I need to adopt AI. But what does the patient think about this?
Let me answer that from a breast surgical oncologist viewpoint as opposed to a radiologist viewpoint. In New York and Connecticut, as David said, there are multiple practices charging cash for AI to read your mammogram in addition to the breast imager or radiologist. I have never heard a patient tell me they said no.
Okay.
I've heard both. I had a family member call me up outraged about it because she works in a school and she thought that it was totally unreasonable to ask people almost living paycheck to paycheck to have to decide whether they're buying a better test or cheaping out on their healthcare.
That's answering a different question. But it is. Michael's question is, no, what are their thoughts? Are they accepting it? What you're just referencing to is patients are outraged that they have to pay extra for it, and now it's creating a two-tier system. But do patients want it?
I have had almost no patients ask for it. I'd much rather have patients ask for someone who reads mammograms on a daily basis. Like, I'll pay $25 extra not to have a neuroradiologist read my mammogram this year. Thank you very much. Like, that would be a much better investment in their care.
But I think they don't know. They don't know that. They don't know about AI. I have patients who come in with 2D mammograms. They don't know that that's inferior to 3D. So no matter how we look at it, there's inequity. And that's unfortunate. I'm blown away at how many imaging facilities still have 2D mammograms. And now it's 2D mammograms plus AI because they can charge for that. Well, AI is not going to make up for all that inferior technology that you have. So I think patients just don't know.
I think that's right. When you start to talk to people about AI, there's this general sense of it's invading my privacy. And I don't trust AI. Like, I don't want anybody to know my information. But then we point out that we pay our taxes online and we go through airport security. We've given up so much of our privacy for things out of convenience. And yet, when it comes to our healthcare, which is perhaps the most important part of our lives, we accept blindly. I'm amazed, Susan, when I tell a woman that she needs a biopsy, once a year, someone says to me, how many of these have you done? I'm blown away. And yet
I am still waiting for someone to ask me if I'm board certified. I work so hard to do that. And no one has asked me that.
No one has ever asked me, how do you know I need a biopsy? If you buy a computer, we spend hours debating whether we need 32 or 64 gigs of RAM. We don't spend 1/10 of that time analyzing who's telling us we have breast cancer or not. Mm-hmm. So I think patients don't know to ask. Most docs don't know to ask. They send their patients to whoever they might golf with or whoever's been nice to them. Like, how do you know whether your surgeon's technically competent? I mean, Susan, I remember there was a doctor, horrible hands, but was smooth as molasses, but everybody loved them. And we knew, but patients didn't know, right? And so the answer is, how do we educate people how they get their best health care? Because they trust us, but maybe they're not so smart to trust us.
We are definitely off to a great start with this two-part episode, and I'm certain that our listeners are already looking forward to part 2, where we'll be looking into the future of AI in breast surgery, radiology, and everyday life. But also, just as important, we'll look into the moral, ethical, and medical considerations that we definitely need to navigate along the way. David, it's truly been a pleasure having you with us on this special two-part episode of The Next Breast Thing. I know I'm already looking forward to part 2.
Susan, thank you so much. I think we all can agree that we are at an inflection point, not just in healthcare, but in all aspects of our lives, with this explosion of AI into all aspects of everything we do. And I'm daunted, excited, nervous, optimistic about everything that it's going to do to make our lives better.
Thank you again, David. To our listeners throughout the entire breast community, we're so excited you've joined us on this journey, and we'll see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host, and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla, Ellie,
Michael,
Susie,
and Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.